Chief of Congress and entire scientific committee for opportunity to present our work and extend appreciation for my assistant, Dr. Sharbeti. Please go to a slide. Today, I will be presenting our finding on obesity paradox in STElevation myocardial infarction in hospital and one-year outcomes from Kermanshah STElevation myocardial infarction registry. Let me start by framing the clinical context. STElevation myocardial infarction or STElevation myocardial infarction remains a leading global cause of mortality and morbidity. It is most severe form of myocardial infarction, responsible for more than 35% of all myocardial infarction cases, and it continues to carry substantial in hospital and long-term mortality despite major advance in reperfusion therapy. At the same time, we are facing a global obesity epidemic. Obesity is closely linked to diabetes mellitus, hypertension, and hyperlipidemia, and it increased prevalence of acute coronary syndrome. A BMI of 30 or higher is associated with multiple cardiovascular risk factors, and its global prevalence continues to rise rapidly. Yet, paradoxically, despite this well-documented association with cardiovascular disease, a growing body of literature suggests that the obesity may actually confer a survival benefit after myocardial infarction. Several studies have shown that the patient with the normal BMI may in fact experience worse outcome than those who are overweight or obese. This phenomenon, widely known as obesity paradox, has now been observed across multiple international registries, yet underlying mechanism remains a matter of ongoing debate. Given the background, our study was designed with three specific objectives. First, to determine existence of obesity paradox over 1 year follow-up period among STElevation myocardial infarction patients. Second, to examine association between the body mass index category and in the hospital outcomes. And third, to assess association between BMI category and both 1 year mortality and measure adverse cardiac event or MACE. To address this objective, we conducted a hospital-based study using Kermanshah STElevation myocardial infarction registry. This registry is based at Imam Ali Cardiovascular Center, affiliated with Kermanshah University of Medical Science, located in western of Iran, a referral center serving a population of more than 2 million people, predominantly of Kurdish ethnicity. Our study period extends from July 2017 to May 2019, during which a total 2,397 STElevation myocardial patients were enrolled. Data were collected using European Observational Research Program forms by trained staff and subsequently verified by general practitioners and adjustment according to European Observational Research Program standards. All statistical analyses were performed using the static version 14.1. A study was approved by the Research Ethics Committee of Kermanshah University of Medical Science under approval number. Informed consent was obtained from every participant, and full data confidentiality was maintained throughout. For purpose of our analysis, patients were classified into 5 BMI categories, consistent with international standard. Underweight with BMI below 18.5, normal weight between 18.5 and 24.9, overweight between 25 and 29.9, class 1 obesity between 30 and 34.9, and class 2 obesity more than 35. Regarding eligibility or inclusion criteria required a confirmed STElevation myocardial infarction diagnosis, age over 18 years, and signed informed consent. We exclude patients with life-threatening comorbidities such as cancer or severe renal or hepatic disease, as well as those with incomplete clinical data. STElevation myocardial infarction diagnosis was established according to third universal definition of myocardial infarction, jointly issued by the AHA. Requiring chest pain lasting more than 20 minutes within preceding 24 hours, together with EKG evidence, ST segment elevation, or new left bundle branch block with adjustment by trained physician follow the European observation research standard. Turning now to our result. Among 2,397 patients enrolled, BMI distribution was as follows. 43 patients or 1.79 were underweight, 38.97% had normal BMI, 43.30 were overweight, 13.43% had class 1 obesity, and 2.5% had class 2 obesity. Taking together, combined prevalence overweight and obesity on our cohort was 59.23%, while prevalence of obesity along BMI 30 or above was 15.93%. This figure places our population within the broad range reported internationally, though as well we discussed shortly somewhat lower than several comparator cohorts. When we examine baseline clinical characteristics across the BMI category, several significant associations emerge. Underweight patients with BMI below 18.7 tend to be older, more frequently male, more often current smoker, and more likely to be AC inhibitor and beta blocker are statistically significant at p-value. Patients with class 1 obesity BMI between 30 and 34.9 showed significantly higher rate of diabetes mellitus and hyperlipidemia, along with elevated triglyceride level compared with p-value. And patients with class 2 obesity BMI 35 or above demonstrated significantly higher rate of hypertension, elevated LDL and HDL cholesterol, and higher ejection fraction with p-value less than 0.05. Moving to cardiovascular outcome, summarized here in what was originally Table 2 or manuscript. Patients with class 1 obesity demonstrated significantly lower rate of MACE-3, that is myocardial infarction, stroke, and death, with significant p-value, and MACE-5, which adds unstable angina, and heart failure to that composite compared to the patient with normal BMI. However, patients with BMI 30 or above encompassing both class 1 and class 2 obesity had significantly higher incidence of percutaneous coronary intervention after primary reperfusion. We also observed that statin use was significantly higher among the patients with the normal PMI. In short, class 1 obesity was associated with significantly lower MACE-3 and MACE-5 rates at 1 year compared to normal weight patients, while a BMI 30 or above was independently associated with greater PCI utilizing following reperfusion. This is perhaps the most important slide of our presentation. Here we present odds ratio with 95% confidence interval for cardiovascular complication originally reported in table 3 of our study. Class 1 obesity BMI between 30 and 34.9 showed a clear protective effect. The odds ratio for cardiovascular death was 0.5 with 95% confidence interval of 0.3 to 0.84. For MACE-3, the odds ratio was 0.47 with confidence interval of 0.29 to 0.76. And for MACE, the odds ratio was 0.59 with confidence interval of 0.44 to 0.79. All of these represent a statistically significant reduction in risk. Next slide. Let us now place our finding in context of existing literature. As noted, prevalence of obesity on our STElevation myocardial infarction population was 15.93%, and combined prevalence of overweight and obesity was 59.23%. These figures are broadly consistent with, though somewhat lower than, several comparable cohorts. Sandford and colleagues reported approximately 75% of their STElevation myocardial infarction as overweight or obese. Next slide. Now, how should we interpret the apparent protective effect of class 1 obesity? This is where caution is essential. When we perform multivariable adjustment, unadjusted lower death and MACE rate observed in obese patients largely disappeared. This strongly suggests the presence of confounding factors. Indeed, patients with class 1 obesity in our cohort were on average approximately 7 years younger than normal weight patients. We also observed that the statin use was higher among the normal BMI patient, which may further obscure any true treatment outcome relationship. Taken together, apparent protective effect of obesity may not reflect a true biological benefit, but rather unmeasured confounding, particularly young age and difference in comorbidity burden. At the same time, our finding regarding class 2 or severe obesity point to a threshold effect. We observed an increased adjusted odds ratio for this 1.49 and for MACE of 1.46 in this group. This is consistent with work of the Midland and the colleagues who reported a BMI 40 or above was associated with higher mortality. Extremely obesity affects the cardiac hemodynamic, cardiac anatomy and function, and myocardial perfusion. All plausible mechanism for this reversal of apparent protective trend. Our findings are also consistent with a broader body of supporting literature. Nitzela and colleagues in 2014 reported 30 to 40% of level this risk among obese MI patients at 1 to 3 years. Next slide. In conclusion, let me now bring this finding together into our key conclusion. First, we did observe an obesity paradox. Class 1 obesity with BMI between 13 and 13.4.9 was associated with lower cardiovascular deaths and MACE over 1 year among our STElevation myocardial infarction patients. Second, this protective association does not extend to extreme obesity. A BMI 35 or above was associated with increased MACE3 as ratio 1.1 and MACE as ratio 1.46. Third, this protective effect largely disappears after multivariable adjustment, suggestive it is likely driven by unmeasured confounding, particularly the younger age of all class 1 obese patients, rather than a true biological benefit of excess adiposity. And finally, our data point to a likely threshold effect in which mild obesity may appear protective while extreme obesity is clearly harmful, consistent with U-shaped relationship between the body mass index and cardiovascular risks after STElevation myocardial infarction. Strength and limitation. Before I close, I would like to acknowledge both strength and limitation of our study. Among its strengths, this represents the first large STElevation myocardial infarction registry conducted in Western Iran, evaluated by experienced clinical professionals using validated European Observation Research Program data collection forms with rigorous multi-level quality control. Our sample size was 2,397 patients substantially, and cohort is representative of Kurdish and Iranian STElevation myocardial infarction population. That said, several limitations must be noted. This was an observational, non-randomized design. We did collect data on the weight circumstance or body weight distribution, which may provide a more accurate measure of adiposity than BMI alone. There may have been variation in post-discharge care across different referral sites. As a single center study, generalizability of our finding to other populations may be limited. And finally, our follow-up was restricted to 1 year without longer-term outcome data. In summary, our finding from Kermanshah STElevation myocardial registry add to growing international evidence and obesity paradox in STElevation myocardial infarction, while also highlighted is important limit. Thank you. I would like.
Thank you so much for your valuable presentation, Dr. Ali. Now the session is open for question and answers. Does anyone have queries? Please raise